I'd like to lead over to the questions. Who's got the first question? Here we go. Damien.
Hi.
Thank you from Queensland.
Thanks, Jan. Bill, I've got the classic two-part question, but for Bill and then for the panel in general. Just with your literature search, was there any studies in relation to silver in comparison to Sorbact? Yep.
Yeah, there were a couple of...
Yep, it's on. It's on.
Okay, good. Yeah, there were a couple I presented in the actual presentation that were actually comparing silver to Sorbact, and it was superior. Mm-hmm.
So, and I suppose that the mechanism of the superiority for the panel, it's something that always interests me, is the what level of, if you're putting on a bactericidal, so silver, you're killing bacteria. Is it the fact that the Sorbact is actually removing the bacteria which is causing the problem, or are we stopping that bactericidal effect, endotoxins being released into the wound, and is that causing a major problem? And are we looking at is that an endotoxin factor that could be the efficacy of Sorbact?
Well, I think it's probably both. You certainly are removing larger amounts than you would with the kill, I suspect. The other thing too, with some of the kill research I've looked at, it seems like when you destroy the wall of bacteria, you end up with bacteriospheres, which still can be quite active in the wound. So it might be that the destruction of the bacteria is still leaving you some remnants that are still creating problems, where the physical removal is actually probably reducing your bacterial count, I suspect. But yeah, so I think it's what's going on.
Yeah. Thanks, Bill. Oh.
Part of the problem with your bactericidal products is that many of them are cytotoxic. So they're actually going to damage tissue as well as killing the bacteria. Interestingly, in the study that I quoted, they showed that with Sorbact you get less toxin production. So it seems to have an effect on the toxin as well. So I think that's probably part of the thing, because many of these bacteria, even though you've killed the bacteria, the toxin is still present, and the toxin is what's doing the damage as much as anything. And the silver or the iron and others are not going to have any effect on the toxin at all.
Okay, another question?
Hi, Janie from Victoria. I was wanting to ask Kerrie, I guess, about a venous leg ulcer, and so quite commonly we will be dressing those on a weekly basis. So I must admit that if I think that there's a slowing of the healing and we've got our sustained compression being effective, that I would tend to usually use a sustained release silver dressing, say, that would work for the 7 days. My understanding has been that I should consider Sorbact for use, depending on exudate levels, for changes every 3 to 4 days, or if highly exudating, more frequently than that. Do you mind commenting on it?
Again, it goes back to what your goal of therapy is. We have used Sorbact for 5 to 7 days, and based on in the country, if it takes and you would relate to this too, if it takes the community nurse 45 minutes to get there, we might say if the patient is improving on doing that weekly regime, then we would continue doing a weekly. If they were not improving, then we would go back to the recommended guidelines. And I'm giving you real facts, folks. I'm not sugarcoating it here. This is the reality of it. I have a catchment of 250 kilometers, and so patients can't keep coming back. And so but it's going back to the basic principles of wound management, assessing, is this effective for them? And if not, then changing and making it more frequent. So we try to stretch the friendship a little bit, but if it's not meeting the clinical need, then it's just a false economy, right, for them and for you. So then we would go to more frequent changes. And that's based on the patient's clinical outcome, but as well as the wound is, is the moisture management not being. So it's the basic principles. But the reality is, yes, we do stretch the friendship at times. Margo, you want to?
Yeah. in looking at venous leg ulceration, I might not go with a single layer. I might do 2 layers on there, a couple of layers, because I'm going to wrap that leg up and let it alone for a week. And you know that when you've put a layer on, it may move around, and so you want the other layer on top of that. And it's still cost effective. I'll bring them back, I'll do a dressing once a week, so I don't have a problem with that.
Well, can I ask a question? From the experts of the product, what would you say about that?
Thank you, Terry. No, actually with Sorbact, and it was mentioned in Bill's presentation, there's actually no maximum binding capacity to Sorbact. So in fact, Sorbact can stay there as long as you want. It's actually your management of the exudate, and the best practice says change Sorbact when you change the secondary dressing. I know in our range we do have secondary dressings, but with the primary dressing, that's the best practice.
I was just going to say, at the lymphedema conference recently, we were talking to the lymphedema therapists, and we often see what they do is they put the Sorbact compress onto the wound and the secondary absorbent dressing and wrap up, and the patient can, because they're using more of these Circade self-wraps, the patient undoes it, changes the secondary dressing but leaves the primary dressing intact. And that's been working very efficiently for many, many people.
Yeah, I was going to say a quite similar thing. I actually see quite a few patients who have substance abuse issues, and they do their wound care predominantly at home because they're not often welcome at GP clinics to do their dressings, so we teach them to do their dressings themselves. And notoriously they use Sorbact compress, and it can sometimes stay on for about 10 days. And although I try and tell them, yeah, about 6 would probably be good, but they change the secondary dressing. And we don't always get good results in healing, because often these wounds aren't wounds which are necessarily going to heal. But we find that people can manage these wounds at home in a situation where otherwise they probably would be walking around with just nothing on their legs. So for those patients, Sorbact compress and changing the secondary dressing, possibly not as frequently as I would like, has sometimes we've found to be a really effective method of treatment.
Thanks, Sally. So we have another question over to the side here.
I have another answer.
Beg your pardon, Jeff.
Yes.
We'll get it in a minute.
The frequency of changing the product is directly dependent to the level of bacteria in the wound. If the wound is relatively clean and just colonised, well, then you can leave it on for a week, and that is not an issue. If it is grossly infected, then you have to change it far more frequently. So it's directly related to the level of bacteria in the wound as to how often you need to change it.
There for a question.
It's not so much a question, but a comment. A lot of our patients... Thank you. Terry, because this is actually directed at you. A lot of our patients these days, we have high-risk surgical patients, diabetes, obesity, the risk of surgical site or infection and wound dehiscence is increasing. And only once has a surgeon run after me in the corridor and said, what on earth did you put into that wound that has really changed the wound environment? And it was Sorbact ribbon in a surgical site infection and wound dehiscence. So one of the things, that's the first time a surgeon has done that, and to really see a good response to therapy quite rapidly. And so to reiterate what Terry said about radiopacy in these packing wounds and in the gauze Sorbact, I think would be a really important step that you take. Yep.
Next generation.
I do have one for Bill at the moment. I wrote this down, Bill. First I said, you've eloquently described hydrophobic, and yet the bacteria are attracted to Sorbact. So I was confused between hydrophilic and hydrophobic. But my question really now, since you described that so well, is what is the benefit of hydrophobic bonding over the mechanical entrapment of bacteria by some fibrous dressings?
The intent of bonding, it's like mixing with your mates versus going to a bar with people you don't know, is that by bonding you actually, what you're doing is increasing the bacterial retention within the product. So when you're relying on just secondary snaring, if you like, or secondary entrapment, it's hit and miss. you know, about what it's picking up. How much... You'll always get bonding in any aqueous environment, but if you haven't got a very wet wound, for example, fairly dry, you're not going to pick up much, where the bonding still enables that to occur with that hydrophobic attraction. And most of the pathogens are hydrophobic. There are some hydrophilic pathogens, and there are some bacteria that are hydrophilic, so they're not going to work so well on them. And Geoff talked about how it actually leaves behind more of the beneficial flora. But certainly most of the things like Pseudomonas, E. coli, I think, they're all, staph, they're all hydrophobic. So actually the benefit of having something that attracts the bacteria into the product is better than relying on haphazard snaring, really. Yep.
My question's actually a clinical one in respect to different types of wounds. Has anyone had good results on pressure injuries?
Yes.
Yeah.
And I have too.
Yeah, and staging...
All stages.
All
But
stages.
then, again, we're talking about choosing the product depending on what stage you're at, what the clinical condition of the wound is. It's really not, from my perspective, it's no different to any other mix of wound that I see. I try to mix the product with the conditions that I see and what, is going on. I would probably, if it's a fairly dry sort of pressure injury, I'd probably go for the foam. Would be my number one. But that, again, based on the conditions of what is in the wound.
So I have 2 pressure injuries that I can speak about. One is a lady who I was asked to the private home. She had 3 topical negative wound pressure devices on, and she'd had them on for 7 months. So I was called in due to the cost. I was appalled. I actually rang the company saying, your guidelines say 1 month and possibly a few more weeks. How did this ever happen that this husband had to pay for these things for 7 months? So straight away, I needed a cost-effective dressing that would do the job. I've used Sorbact since 1980 because it was actually in the country when I was doing plastic surgery and then disappeared. So I was very well aware of it. I suggested we try it. One of her wounds was 18 centimetres long. That was the right ischium. Her right hip wound was 5 centimetres deep, and that healed in 6 weeks. The ischium that was 18 centimetres long is now 13, so it's 5 centimetres shorter, and her other wound is well on the way to healing. The other patient I'd speak of is in an aged care facility, and he is a spinal patient. He's a very, very intelligent man though, and he's very mobile. And the nurses stated that they dressed his wound with a particular packing, and then when the nurse came to do the dressing the next day, they couldn't find the packing. They searched the bed linen, they searched everywhere, and they couldn't find it. So I was asked to go to see if I could find it. Now, I was absolutely sure it wasn't in there. So I wrote the notes, I am positive this has disappeared somewhere. But so this never happens again, let's use the green stuff because we can see it. And so we switched over, and his wound is doing well. I agree that the radio-opaque would be very good, particularly in post-op wounds, the big Caesar wounds, etc. It would benefit us all, particularly in cases like that. But this is one of the advantages of the product, is its colour, and that it is readily seen. So yes, good success in pressure injuries, from particularly 2, 3 and 4. And yeah, in palliative wounds, the same as the rest. I've had good experience. Are there more questions, please?
Just in
Comments,
relation
Geoff?
to not so much pressure injuries, but we've had great success with pilonidal sinuses with using Sorbact. Really very effective. And the other area that we've had great success is I've had several patients with massive excoriation of fungus under the breasts, and 1 week of Sorbact gel. So very useful for that.
Yes, well, even the ribbon, Geoff, is very good in aged care to prevent intertrigo. So the ribbon under the breast, very inexpensive, but excellent at preventing intertrigo. Toes, podiatrists love it. They wrap around the toes and between the toes, yes, yes. So I have a question, if no one else does, of Margo. So Margo, given that you've got different products in your care range, Have you put a guideline together to help your staff decide when do they use the compress, when do they use the ribbon, when would they use the Sorbact gel? Have you?
No.
No? Do you think it's a good idea that we try to do that?
No. In that, as I said, we had that picture of that sister from many years ago that told you, the non-thinking nurses, what to do. And now we have nurses that think about their practice, and just because it's a Sorbact product, I don't think we have to go, you use A, B and C on these wounds. You have to, your question about pressure injuries is no different to diabetic foot ulcer or burns. It's about what you assess. And so if the burn or the pressure injury, whatever, if your aim of care is to prevent infection because that patient is in a high-risk environment or they are immunosuppressed, and that is your rationale of using an antimicrobial product, so it's your wound assessment of the person, the wound and the environment that you've made your selection. No, it's not about the wound itself. And so I don't believe that we need to have a script of when to use this product or that product. We already have that guideline of wound assessment. That's what we go from, the cornerstone of wound healing principles.
Very good, thank you.
This is for the panel. I do have a problem patient, and I'm just open to suggestions here. We have a patient who has a donor site that's 6 months old, and I have tried Sorbact gel on him, but I'm wondering what you use as your secondary dressing, because when we used it, it dried out, and even though I asked the nurses every day to put extra gel on him, they put a combine, and of course it just dried out because of the airflow to it. Then we tried using Comfeel to seal it all off, so it will stay moist, and of course it got too wet. But then, yeah, what would be a suggestion?
Okay, it's very hard. It's very hard. I'll start because my background's plastics. Very hard without seeing your picture, because the most common reason that my donor sites don't heal, if it's not antimicrobial issues, is that the person suffers with a type of vasculitis. And so we give it 5 days of daily Kenacomb and it's fully healed.
He does have, he's fairly young, I mean he's about 46, and he does have a whole range of comorbidities. He's diabetic, he's obese, he's had fungal infections, he's had bowel issues, and he's also got mental problems as well.
So on that case, without seeing it, and you've considered all those comorbidities, did you think about then putting a mesh dressing? So a silicone or a hydrocolloid mesh, like Ergotool or Siltac.
As the
because that
interface?
Will just, as your
secondary dressing.
As your secondary. So trapping, because so that might just keep enough, because, the problem for often is that many of those will make our wounds too wet. But if you have a wound that's drying when you're putting gel on, you might need just that little bit of occlusion with the paraffin-like or the silicone-like meshes that just hold enough in. I would try that.
I think he's got a lot of issues. We have tried several things, but I might try
Kerrie?
that again.
Yeah. The oldest donor site that's walked into my clinic was 18 months. Now this is a wound that's supposed to heal in 4 to 6 weeks.
Yeah.
That problem was as well. She had a significant autoimmune disorder, but every time it started to heal, she would go back to the surgeon and he'd say, "Leave the dressing off." And so we know what happens when you have a wound on a thigh when you wear clothes. You have that shear and friction. At nighttime you have the sheets, etc. So with a combine or a like product, you are going to get that desiccation. So you're asking too much of that product. But putting a silicone type dressing, and I like an adhesive over a donor site, so you decrease that shear friction. So for me, a silicone adhesive over that Sorbact gel
Right.
eliminates the two things. You're getting that bacteria binding, but you're also decreasing that shear friction that occurs.
So
And
you're talking about a occlusive silicon, like a Mepilex border, or just a Mepitel type thing?
I like the they've used the film, but I like an adhesive. But
Yeah.
when you're trying to get the moisture balance right, and occlusive, semi to occlusive, totally occlusive was too much. That's why I like, because we know if you have silicone foam, you have decreased absorption, but you have that protection from shear friction. Also, this patient, because so the longevity, we knew there was biofilm. So you still have to prepare that wound for the dressing. So that included aggressive cleansing, and also was put on a course of antibiotics because in that patient, the symptoms were masked. I didn't do a wound swab because it was academic.
Yeah.
I mean, it's going to tell me it's going to grow something, but it's not necessarily causative agents. So we did aggressive cleansing and dressings that deal with the microbes and then the shear friction. And she also went on some nutritional supplements because obviously with the wound that's 18 months old, that should have been healed. And she went on to heal, but she was also informed to not cease the dressing regime, even if instructed by other parties of her team.
And also a question for Bayport as well. I'm happy to change my practice based on best available evidence. I use the Sorbact gauze underneath negative pressure as well. I've used hypertonic saline, I've used AMD gauze, I've used normal gauze. The reason I use it is that it's easy to wet, wring out, and it sticks in the wound quite well. If there was proven to be a better alternative, I think that was something I would look at. So I think probably a question for Bayport that I think this is an area that you should really be looking at, is the interface dressing beneath negative pressure. We're finding we're moving more and more into that, and I would like some more evidence to back up what I'm doing in my pragmatic everyday work. Kerrie?
PhD, sitting beautifully there.
Okay, I'd like everyone to put their hands together and thank the panel very much.